I'd rather not. Did you fix it already? Or did the tooth disappear completely? So convenient. All right. Yeah, better. Much better. Yeah, that'll work. I mean, it's again, they're small teeth. They're gonna look tiny, so I think you're okay. Just watch the sharp edges too. Okay, and then stress and cause a fracture like that. All right, here we go.
Thank you.
Okay, everybody survived their Pendex and dentures and all that fun stuff last week. Do you guys want to have lab today? No, me neither. Okay. I think I'm the only one here anyway. If you guys want to talk about teeth afterwards, we can. I think this is slated for a 2-hour lecture. We'll see if I've got it in me to make it that long. But this is an important lecture. I know you guys have radiographic interpretation and things like that, but from a treatment planning standpoint, PEDS is always just a little bit different. And again, we could talk about this for weeks, and this is something that you guys will need to work on. This is actually a lecture that we used to give to you in the spring semester of your fourth year um, after having seen a lot of this, and it really clicked for a lot of the students right before. So it's kind of hard to kind of get it right now, but it's important to start seeing. So if along the way you have any questions, please let me know. But we'll go ahead and get started. So we worked on our class 2 preps and restorations already. But we need to know when to do those as opposed to when we need to do a full coverage restoration of stainless steel crown and or decide that a tooth needs to come out. So again, we always have to keep in mind these teeth aren't going to be there forever, but with what we restore the class 2s with, especially here at the school being Fuji 2 or an RMGI, those really wear down quickly. So that comes into play on why we may not consider doing like MOD restorations or large coverage restorations with just glass ionomer, and why those might require a full coverage crown instead. So when do we do a class 2 restoration? Well, when there's minimal caries that extends into dentin. Okay, so that's pretty much the definition of why we need to do restorations in the first place. Basically what we would used to call boards lesions, which we don't really call that anymore because you guys do boards on plastic teeth. But again, just those perfect little radiolucencies that extend right to the DEJ, perfect. That would require a class 2 restoration. But then there's all these little nuances and differences with primary teeth as well. So incipient caries on the proximal surface of a tooth adjacent to a proximal surface with caries into dentin. So incipient caries in general with primary teeth, if they're standing alone, you might consider watching them. Now, again, with the remaining of this lecture as well, it's important to always consider what's the oral hygiene like for the patient. Is the patient a good patient? Do they come every 6 months for their checkups? Or is this one that kind of comes and goes every 2 or 3 years? If they're not coming in very often, you're probably going to consider being a little bit more aggressive with your treatment planning. But if they're there every 6 months and you have good follow-up and they have good oral hygiene and a parent that's engaged and listens, there's nothing wrong with watching these incipient lesions. But the fact of the matter remains is, one, we're limited now with kind of faculty as how often we can get kids in to be seen for pediatric dentistry here at the school. And two, the difficulty of some of our patients getting here. Again, a lot of the parents are working a lot. They don't have time to get their kids in. And again, there's just limited resources to get these patients in every 6 months. Unfortunately, here at the school, we will schedule a patient to come back, but due to limited faculty, sorry about that, it's hard to get them back in like 3 or 4 months for just one restoration, let alone 4 quadrants of dentistry. So again, we're a little bit more aggressive with our treatment planning here, but you have to consider the whole patient or the patient as a whole in your practice on how aggressive you're going to be with this treatment planning. The next one, caries that does not extend into the pulp. Okay, obviously if there's caries to the pulp or right adjacent to the pulp, we're never going to just do a big class 2 filling unless it's going to fall out in a year or so. Caries with the marginal ridge intact. Now, I purposely removed all clinical photos from this lecture from years past, which I kind of instantly regret now, but I think there is 1 or 2 pictures that we will look at. Basically, if you're looking in the mouth and it looks like somebody's already started a very small class 2 prep, but it's caries, that tooth requires a stainless steel crown, because even though it looks minimal on the tooth clinically, I can assure you that once you start removing that decay, it's going to end up a lot bigger than you anticipate. So if it looks like a tiny little prep has started, but it started just due to caries in the mouth, that's going to require full coverage restoration. This next one's a little wordy. Caries and wicks in the axiopulpal wall and the floor of the interproximal box can be obtained without pulping the tooth. Basically, you're going to be looking at a radiograph and see a class 2 lesion and picture, okay, how much of this tooth am I going to have to remove to remove all the caries and get a nice restoration there. And again, we'll have a picture to look at that as well. Caries on a tooth that does not have caries on the other proximal surface. Again, we really don't do any 3-surface restorations on pediatric teeth. Again, a lot of that has to do with the wear and tear of the RMGI and the length of the time that's going to be in the mouth, but also it has to do with like a high caries index for that patient as well. So again, this doesn't mean that you can never do an MOD on a primary tooth. But here at the school, we kind of teach if we do have to do that, we're going to consider a full coverage restoration. In practice, again, taking the whole patient into consideration, how's their oral hygiene, how's their diet, is the parent engaged, maybe we consider doing some MODs. But here at the school, If it's an MOD, it's going to require stainless steel crown. And then caries that breaks buccal and or lingual contact that will exfoliate within a year. So here's the exception to the rule where we can do either a 3-surface restoration or one that's a little bit bigger than ideal that would usually require stainless steel crown. If it's going to only have to be there for about a year or so, we can get by with one of those large class 2 restorations that goes onto the buccal or lingual surface a little bit, and or a 3-surface resin. So minimal caries that extends into dentin. So where do we see, it probably shows up on your slide already, but so where do we see caries? And we should be able to see here on A and B. Okay, now again, I don't know how many radiographs you guys stare at, but when we have the primary teeth, the enamel is 1, fairly thin, and 2, it's not as radiopaque and thick as the nice permanent teeth there. Okay, so again, on permanent teeth, we're always looking for that nice little triangle of caries, really well defined. Sometimes we can see that on these, but a lot of times it's just this dark line right at the DEJ, or again, I wouldn't really call either one of these a triangle, but again, just some radiolucencies in the area that we're looking. So when you start to get in the clinic and you're really looking at these, everybody has a tendency to really get that tunnel vision and just stare at these contact points. And if you have a tendency to do that, it's really hard to pick out, okay, where are the radiolucencies? Whereas if you train your eyes to just scan across just below with contact points everywhere, and see where it's darker, then you can take a closer look. So again, hopefully these jump out as kind of ideal class 2 lesions, but we're not going to always see that really nice dark triangle like we see in permanent teeth, just because that enamel is so thin and it's not as radiopaque as the permanent teeth counterparts there. So there they are. And again, A needs an MO and B needs a DO. And hopefully we can all agree that these are both into dentin as well. Again, just quick reminder, I prefer you guys use a 330 burr on these primary molars when you're prepping these for MOs and DOs. And again, what this really is trying to show is I talked to some of you about this when we prep these teeth. Again, we don't necessarily want to widen the occlusal portion of our prep, but we have a little pendulum swing of that burr where it keeps the minimal break or no break of the buccal or lingual contact, but we have a nice sweeping motion that removes all the decay. And sometimes that causes a little bit of a ditching at the bottom, kind of a scoop out there. But again, that will allow us to remove all the decay interproximally while maintaining buccal and lingual contact on the occlusal portion of our prep there. Now, so incipient caries on the proximal surface of a tooth adjacent to a proximal surface of caries in a dentin. So again, that's a really wordy way of saying, okay, if I look at this, again, I really don't see a whole lot of radiolucency in the enamel on the distal of B at all here. But I can see that nice, well-defined line right at the DEJ on the distal of B. So again, hopefully we can all agree that we see caries into dentin on the distal of B here. Now, whereas if I look at the mesial of A, I can't call that a nice triangle, but I have this semilunar shape of this radiolucency that is confined into enamel. If on its own here in a vacuum, A is not going to really have a need for an MO composite. But since it's adjacent to a tooth that has caries into dentin, again, we're going to treat this a little bit more aggressively. Caries spreads fairly quickly in primary teeth. Again, we don't know how often we're going to see this child back. We know that we have to do a DO on B. And since we have the start of caries on the MO of A, we're going to go ahead and treatment plan that for a restoration. The fewer times that we have to have our patient come back, numb up, get a rubber dam on, do operative dentistry, restorative dentistry, the easier it is on the patient, on us, the parents, and everybody else. Okay, so we're just going to assume, again, how old is this patient roughly? Whispering 5s, yeah, 5-ish, maybe 4 or 5, yeah, maybe 6, early 6-year-old, who knows? But again, these teeth are going to be there for a long time. Chances are by the time that this tooth is ready to exfoliate around the age of, just pick a number between 1 and 20, it's going to fall out before 20. 12, Dally can live with 12, yeah, 11, 12, yeah. So this is going to be there for, 6, 7, maybe 8 years, all right? This is probably going to progress into an MO restoration. So again, we're going to be a little bit more aggressive. We know we have to do B because that's into the dentin, and we're going to go ahead and restore A because we have the start of a carious lesion there as well. The other thing that we're going to talk about, hopefully I'll remember to keep talking about, I don't know how evident this is, but there's this little triangle on the mesial of A here. Does everybody see that okay? That's not necessarily caries, okay? That's the overlap of the little cuspa carabelli on A, and the same thing happens on J. Don't get overzealous and treatment plan those all the time. Now again, what we're looking at here is this little dark spot right on, confined to the enamel. But this little dark spot here usually is nice, well-defined sharp line. Well-defined sharp lines are not typically caries. Okay, that's some sort of anatomy. The fuzzier things get and the harder it is to say what's the extent of this, it's more likely going to be carious. Does that make sense? Okay, and again, just to kind of exhibit this, this is an 8-year-old patient with progression of decay in B. Now again, this isn't one that we would watch in the first place. We would say, okay, we have decay definitively into the dentin here, and within 10 months, it's approaching the pulp. It's actually obliterated the distal marginal ridge. The tooth is fractured. If we had a clinical picture, you'd see a big hole in the tooth there, and now it requires a stainless steel crown. Whereas before, you could probably get by with a pretty moderate sized DO, but now it's going to require a full coverage crown. The other thing that we can kind of talk about and see is, you know, we might say that we had a little bit of irradiolucency here on the mesial of A. Hard to say exactly, but what we can say is there was a little bit of overlap on the radiograph here. Whenever you have a little bit of an overlap of your posterior teeth, it kind of exacerbates the depth of any kind of carious lesion or radiolucency. Whereas here, this is nice and open. And it's partially open because we lost the distal part of B, but we don't see any kind of radiolucency here. So overlap can, one, lead to kind of false positives of carious lesions, but two, even if we had a watch here, if that's overlapped too much, it's going to make it appear as though that decay extends into the dentin, when in reality we're just kind of catching that off-angle decalcification in that scenario. Is any of this making sense? Have you guys? Yeah. Okay. Good enough for me. All right. So again, caries that does not extend into the pulp, again, kind of same thing. And this is a really good instance here of the cuspa carabelli on the mesial of A. Okay, this dark triangle, a well-defined sharp line here, that's the cuspa carabelli, and it makes this area look really dark. Now, again, to complicate things, we do have a carious lesion on the mesial of A here. Okay, but again, this nice well-defined triangle isn't necessarily carious. Now, clinically, we might be able to see a little bit of a carious lesion in the distal pit. I don't know, hard to say based off the radiograph alone, but we might say that we have a little bit of radiolucency here in the distal pit of A. So again, this is going to require a closer look clinically. But again, just because you see this dark, well-defined triangle here, doesn't mean that that's necessarily a carious lesion. If it were, that would be something that should be very evident clinically. But again, kind of besides the point there. Any decay that reaches into the pulp or the depth of the pulp, we cannot do with we cannot restore with a class 2 restoration. Okay, caries with the marginal ridge still intact. Again, if you were looking clinically in this scenario, this tooth right here, which is tooth, pick a letter between A and T. L, good, yeah. Yeah. Yeah, so again, this is obviously missing a marginal ridge there, okay? So that is not going to, a class 2 restoration is not going to fly there. Whereas up top, albeit this lesion is fairly large on the distal of B, that marginal ridge is still intact. Now, again, this goes back to it. I'm going to say that we do have a little radiolucency. It would confine to the enamel on the mesial of J. So we're going to go ahead and restore that as well. Okay, so this is what happened. So this is a case that happened several years ago here at the school. A couple little disasters happened. Tooth K, if we had a picture clinically, you would see that this is cavitated on the mesial marginal ridge. Again, that's hard to see radiographically, but this decay is fairly deep. It's approaching the pulp, and just believe me when I say that this had a cavitation on the mesial marginal ridge of K. They attempted to restore it with a large, and again, this is how long ago it was, we did a large MO amalgam and ended up pulping it. It failed because we didn't have our buccal and lingual contact, so that the restoration extended onto both the buccal and lingual surfaces. Those don't last very long due to the occlusal forces and the small nature of these teeth. it fractured, it fell out, became carious, and now we have this radiographic radiolucency in the furcation, and we have to extract K. L was extracted, and hopefully if we look on this left film here that we can see that there's a radiographic furcational radiolucency. And again, if we are unsure about that, we look at the depth of decay easily into the pulp chamber on L, extracted that, but again, instead of putting a crown on K, we ended up trying to do a very large restoration, ended up failing, and now we end up losing K as well. Going off on a little bit of a tangent here, if we do end up losing K at this young of an age and we have all this bone destruction, sometimes what will happen is one of two things. Either the bone will heal over and delay the eruption of number 20 here, or if the decay is too bad and destroyed too much bone, this will actually shoot right up into occlusion, and the second this gets into occlusion, the root development stops on number 20. So you'll see some kids that have just blunted roots on some of their premolars because they had such bad decay on the primary tooth, came into occlusion, and the second it comes into occlusion, it doesn't matter how long or how far the root development is along, it will stop. So this does have long-term implications on the patient. Okay, so this is the really wordy one. Caries in which an axiopulpal wall and a floor to the interproximal box can be obtained without pulping the tooth. So again, this is, if we picture the depth of the decay on these, as far as the depth pulpally, how much do we have to remove if we drop a 330 burr in there to remove that decay? Right, this is actually from that first slide. A and B are fairly ideal. Let's see if this works here. Okay, so this would be about the outline and the extent of decay on B. All right, if we removed all of that, we will have removed all of the decay. Now we obtain that removal by dropping a burr in from the occlusal. So that's our line straight in, and then we go to the depth of removal of decay to make our gingival floor. So again, this is a 330 burr dropping in there, and that's how much tooth structure needs to be removed to remove that carious lesion there. Whereas on the bottom, this decay on L is not into the pulp, but if we were to remove that by dropping a box and to the depth that's necessary, we are going to intersect with that pulp horn there. Okay, does everybody see how that works? So again, even though this wasn't into the pulp, by prepping for a class 2, it's going to cause us to intersect with that pulp horn. Now let's assume this tooth is asymptomatic. It is the decay is deep, so instead of doing a class 2 restoration on there, we'll end up doing a stainless steel crown. That will allow us to prep this tooth without intersecting that pulp horn by removing tooth structure at this angle with like a 169 burr. So again, we'll get into the preps of stainless steel crowns later, but just knowing when to treatment plan them is going to be important. So same thing. This unfortunately was prepped with a class 2, and again an amalgam here. Again, the decay was not into the pulp. Somebody prepped it and didn't realize they were into the pulp, and the reason that is because this was probably fairly healthy. The actual pulping of the tooth was probably fairly minimal, just caught a little bit of a pulp horn. And again, when we think of things as like, oh, I ran into the pulp of the tooth with my burr, you're expecting to see a ton of blood all the time. Healthy primary dentition, if you run into the pulp, a lot of times it just looks like the outline. It may or may not have some blushing. If you have blushing, you've definitely pulped it, but it might even just look dentin colored with a little outline of what you would assume to be the pulp. You're in the pulp at that point in time. That's too close for a primary tooth. It's pulped. You need to do a pulpotomy and then put a stainless steel crown over it. So again, it's not necessarily a terrible thing that somebody did. They just unknowingly did this. You'll see this a lot in private practice as well, from a lot of family dentists that just don't know any better, and that's okay. That's why we're teaching you guys all this stuff. This radiograph is a little bit darker. Well, it's a lot darker, and it's harder to see. We have a radiolucency here in the furcation. That radiolucency does not necessarily extend all the way down to the developing tooth bud of number 21 here, but is actually confined into probably the upper third towards the furcation here. Okay, so we can see this lamina dura and the PDL space kind of extending up the roots on L a fair amount, but right above that it kind of disappears. This is the furcational radiolucency. Down here, there's still a little bit of trabeculation, albeit it's darker in there. That is not a furcational radiolucency. Same thing can be said, again, you guys don't see a ton of these, but like this looks darker to me in the furcation, right, on K, but there's no furcational radiolucency there. If we follow the PDL space up in the lamina dura and we see trabeculation everywhere, it's healthy. The other thing is there's really no decay on this teeth, and if you tapped on it, you're probably not going to get any response. So again, that's kind of a difficult thing to look for and start to recognize as you look at these radiographs more and more. But again, kind of a telltale sign is things get a little bit fuzzier around here. Now again, they're both dark. There's even some darkness down here on L, but there's still a little bit of trabeculation, and this is kind of fuzzy and not so well defined. Same thing with caries. It's not really well defined there. This is how the restoration looks intraorally. Again, even if we didn't know that we pulped it, we should go ahead and assume that this is too far out onto the buccal surface for us to put a class 2 restoration in. That requires a full coverage restoration. Again, this patient is fairly young. It's going to be there a little bit while longer. It's not going to hold those occlusal forces very well, and frankly, that tooth isn't even going to hold the restoration very well. If your prep looks like this and the tooth is not going to exfoliate within a year or so, it requires a stainless steel full coverage restoration. We went way past the breaking buccal contact on tooth L here. We even broke contact on the lingual a little bit, but not too bad. You might have, and again, if I'm staring directly at this interproximal lesion between 19 and K here, I might not see this. But if I'm training my eyes to kind of scan, again, just below the contact point of all those, I'm going to see some darkness here. I see this dark line. We have a DO lesion on K. Since this tooth has already been restored, we're not going to turn it into Swiss cheese. We're not going to have to do a third prep on this tooth. We're going to be done with it and put a stainless steel crown on this tooth, a full coverage crown. Again, kids aren't really big fans of having to do the same tooth multiple times. Parents aren't either. Again, we're going to be a little bit more aggressive with this. Again, if you wanted to do a DO on there, there's a chance that the mesial might fail. You might get a buccal lesion on that, a cusp might fracture, and then you're going to have to work on this tooth a third time and put a stainless steel crown on it. Whereas if we recognize this, even though it's very tiny, we're going to go ahead and put a full coverage crown on there and just be done with it. It'll fall out naturally on its own. And we have a nice pulpotomy and crown on L. Do we see any other carious lesions on this radiograph?
Yes.
Yeah, okay. Yeah, we do. Now, since you said yes, which tooth? Yeah, I can live with I, but mostly, yeah, J, right? J is a definite carious lesion there. Now, again, we talked about looking for that triangle with the overlap of the cuspicarabelli here, but this is a little bit more fuzzy and not as well defined. So we have a fair amount of decay on the mesial of J, but yes, there's a little bit on the distal of I. This down here is more cervical burnout than caries. You're not going to see carious lesions like this too much. And again, we talked about the overlap of cuspicarabelli. The other thing that's tricky with these maxillary teeth is you actually get the overlap of the root. So we can see the distal root here, and that causes that shadow on the distal, or on the on the distal of I. Okay, so whereas I agree that this is radiolucent a little bit, a lot of that has to do with just a concavity on the distal of this tooth and the overlap of that distal root there. So this isn't necessarily carious down here. You probably have a little bit of caries here, but mostly on the mesial of J is decent. Okay, so, and then again, here's our exception to the rule. Caries that breaks the buccal or lingual contact on a tooth that will exfoliate within a year-ish. So here's a 9-year-old patient with large caries on the distal of I. Clinically, this will have removed the distal marginal ridge, but it's not going to be there very long. We just want to avoid food impaction and progression of decay to cause any discomfort. We'll put a nice little DO in there and let it fall out. Now, if this were a 4 or 5-year-old, this absolutely 100% needs a stainless steel crown. But since this is just a stopgap to make sure this doesn't progress, and again, assuming this tooth is asymptomatic, we'll just put a nice big DO in there, have it last about a year or so, and be done with it. Primary teeth, you can always get a nice educated guess on how long they're going to be there, but primary teeth have a really good tendency of making, or at least me, look like an idiot when I say, yeah, a tooth will fall out in no time, and it's there 2 years later and causing pain, or no, we absolutely need to fill this. I fill it, and then 2 months later it falls out. Teeth are mean sometimes. So again, you do the best that you can as far as estimating how long things are going to be there. It's never going to hurt to fill a cavity. Now, if this tooth is mobile when you're prepping it, it probably just needs to be taken out or let it fall out on its own. But again, assuming this is a 9-year-old, you probably only have a year or so left to have it in there. Tooth number L, there's too much space loss to do anything with, okay? It's not fixed pros, but you still need some sort of pathodraw or access to the tooth. We might have a little bit of overlap on our radiograph here, but we've lost so much space that it's going to be impossible to even put a restoration in there. So in this case, L needs to be extracted. Okay, so when do we do stainless steel crown instead of a class 2? You know, basically the opposite of everything we just talked about. So again, caries that extend into the pulp, maybe, and that maybe is because we need to know if it's symptomatic or not. Now, it has to be truly symptomatic. If food gets impacted in a tooth, that can be uncomfortable. That does not necessarily doom the tooth to be extracted. True spontaneous nocturnal pain means that the tooth needs to be extracted. Now, we'll talk about that a little bit more. We'll get through this list, and I'll give you some other instances there. Caries with the marginal ridge not intact. Again, if it's going to be there for more than a year, that's something more evident clinically than radiographically, but you can see that radiographically as well. Caries that breaks buccal or lingual contact, same thing, as long as it's going to be there for more than a year, because the tooth will not be able to hold that restoration very long.